everyone. Myself, Dr. Sanjay Khatri. We are here, clinical history based MCQ in pediatrics. Yeah, there is a trend. History is given, clinical question, and you need to identify the condition. Yes, we are discussing few important MCQ here. I assure you, you will be clear in your concept on those history based questions. Yes, before that, note this. NEET PG 2023 Achiever Batch. Achiever Batch. Yes, Unacademy started first. 500 slots full. Now, on popular demand, further slots are arranging. That start from 30th November. So be there. If you are not registered, register this in this batch and feel the difference. All the top educators and the name Achiever Batch. Yes, we are going with the full speed with good MCQs which will help you definitely to crack the exam. Achiever Batch. You mean it, na? Yes. Yeah. Some very good key MCQs will be there. And then MBBS Prof subscription. Start from the beginning. Why you want to wait? So just either first prof, second prof, or third prof, based on your choice, whether you want it for first month, 2 month, 3 month. Take, yes, start from the beginning. Yes, just read pathology, microbiology in different format. Definitely come on the platform. So today, read this first question. I hope you will be able to answer. Read this question. 8-month female child present with severe developmental delay, vomiting, blue eye, fair skin, rash is there. Deep tendon reflex are exaggerated. Microcephaly. What is this? It is torch, galactosemia, phenylketonuria, tyrosinemia. What is this? Yes, yes, yes. Paul, you are right. Paul Praveen Kumar. Yes, it is phenylketonuria. Clinical question. Why I am calling it phenylketonuria? It's a classical triad of brain damage, vomiting, and rash. All three are given. Brain damage, severe developmental delay, exaggerated deep tendon reflexes, failure to thrive, vomiting, rash. All three are there. It is phenylketonuria. Galactosemia, nothing is given about cataract. Tyrosinemia, nothing is given about liver involvement. Torch infection, why? Rash is there, but why vomiting occur in torch infection? So remember, this is the classical triad of phenylketonuria. Yes, this is phenylalanine. In the presence of phenylalanine hydroxylase, it will convert into tyrosine. It will convert into tyrosine. What happened in phenylketonuria? There is a deficiency of phenylalanine hydroxylase enzyme. So phenylalanine increase and it will convert into its metabolite, phenyl pyruvic acid, phenyl lactic acid, phenyl acetic acid. Elevated level of phenylalanine causes brain damage, having intense vomiting sensation. And further, if elevated phenylalanine, there is an enzyme tyrosinase which convert tyrosine into melanin. Exaggerated phenylalanine level inhibit this enzyme. So no melanin, no skin pigmentation. That's why eczematoid rash. A very good clinical question. Remember, brain damage, vomiting, and rash. What is this? This is phenylketonuria. It is due to deficiency of phenylalanine hydroxylase enzyme. Okay. Second question. Read. This is again an important question. Yes, Dr. Doom. Happy to see you in the class. Yes. I miss few students in the class. You are one of them. Okay. A full term newborn having episode of cyanosis, which are worse when he attempting to feed but seem better when he is crying. So just make it simple. What simple? Cyanosis increase when you feed the child. Cyanosis decrease when child is crying. This is the history based question, clinical question. You can identify. Even nursing staff can report to you, sir, I feel that blood circulation is more when we give the feed to the baby, and when baby is crying saturation reaches to 95. Okay, so crying cyanosis increase, it is the classical of cyanotic heart disease. So these two are easily ruled out. It can't be tricuspid atresia, it can't be pulmonary atresia, because in both two condition cyanosis increase when child is crying. But another question, cyanosis decrease when child is crying. So this is not there. So what is this? This is the classical history of choanal atresia. You just imagine both nostrils are closed, both nostrils are closed. Then you feed the baby. From where baby take the respiration? Yes, from where baby take the respiration? So cyanosis increase when you feed the child. It classical of choanal atresia. Clear? Clear? Cyanosis increase when you feed, choanal atresia. Cyanosis decrease when baby is crying, choanal atresia. In cyanotic heart disease, decrease pulmonary blood flow. Cyanosis always increase when you with the child is crying. But here cyanosis decrease when child is crying. When increase? When you feed the baby. It is the classical of choanal atresia. Okay, you are in the nursery. You find this history. You try to put the nasogastric tube. It's not going because it's a choanal atresia. Block is there, not going. Then it's an emergency. Yes, you need to call a pediatric surgeon and go for the surgery. Okay, but when surgeon comes, na, you are intelligent. You are posted in the nursery. They will ask you, doctor, whether it's a isolated choanal atresia, it's isolated choanal atresia, or it's a part of charge syndrome. What is charge syndrome? What is charge syndrome? C for coloboma, C for coloboma, H for heart defect, A for atresia, that is choanal, R for retarded growth, G for genital abnormality, E for ear anomaly. Yes, you are posted in nursery, so you can answer surgeon easily. Before surgeon come, get the eye examined. You find coloboma, get a echo done. If heart defect is there, ear are abnormal, sir, it's a charge syndrome. Then family counseling in a different way. If it's isolated choanal atresia, you can go for the surgery. But associated defect, genital anomalies, ear anomalies, heart defect, retarded growth, eye abnormality. So always remember, this is the classical history of choanal atresia, whether it is isolated or it's a part of charge syndrome. That is the challenge. Sir, what heart defect seen in charge? The most commonly heart defect seen in charge is VSD and TOF. VSD and TOF. Charge syndrome. When we called about heart defect, it is VSD and TOF in charge syndrome. Okay. Sir, should it be bilateral choanal atresia? Yes, it can be bilateral. That's why it's very severe. Bilateral is very severe. I see few cases. It's very severe. It's real emergency. Okay. Bilateral choanal atresia. Then child is always take respiration from the mouth and always in distress. Yes. Charge syndrome. Always remember this clinical history and charge syndrome. Answer this question. Try to read. That give you a feel of real clinical question. I hope you can answer it. You can answer it. 6 month presented in OPD. Well child visit. 37 week of gestation without any complication. Temperature normal. Pulse normal. Blood pressure 82/32. Pulse pressure is wide. Respiratory rate normal. Currently 50th centile for weight and 75th centile for height. So nothing is specific. It is how the clinical question come. They give you a history to build the topic, then suddenly ask. History is given, not a single point significant. Now, she is acyanotic. No cyanosis is there, but bounding pulses. This is the first point. Why pulses is bounding? And 3 by 6 continuous murmur at left infraclavicular region. Infant continuous murmur over left infraclavicular lesion, acyanotic. Only one possibility, that is PDA. This is the classical finding, but examiner want to check your patience. Yes, whether you are able to read the question properly. If you read, then all the classical finding in last two line: bounding pulse, continuous murmur over left infraclavicular lesion. Yes, it is PDA. It is PDA. Suppose it is ASD. First four lines are same, acyanotic till, but in ASD, examiner will give you second heart sound, wide and fixed split. Examiner want to write history ASD. So he will give you the classical finding of ASD. Suppose is coarctation of aorta. One universal line. Femoral, not palpable. In the question. Well, radial, well palpable. Femoral, not palpable. Only one answer. Coarctation of aorta. If it's a VSD, then pansystolic murmur should be there. So the classical finding of a lesions, try to identify. Just one question from my side. What is the name of PDA murmur? Anybody in the comment box? Yes, Paul, Doom, Akshata, Dipti. What is the name of PDA murmur? PDA murmur is known as, you can write machinery murmur. Okay, but I want to know a specific name. Gibson murmur. Oh, yes, yes, yes. Yes, PDA murmur is also known as Gibson murmur. Very good. Very good, Akshata. It's a Gibson murmur. Answer this question. Read with patience. Classical clinical question. Common clinical scenario which you will face in your day-to-day ward posting. Read. I will not speak for 30 seconds. Read and concentrate. Answer. Put answer. Whatever question you know, put some answer in the comment box. Okay, I will explain. You can put answer in between also. See, 2 year bring to the emergency with seizures. Child is having seizures. Okay. Having fever 102. Fever with seizure. It can be febrile seizure or it can be meningitis. Parents are happy. If seizures with fever, it has to be febrile seizure. But when it is simple febrile seizure, simple febrile seizure, yes, some of you will definitely have simple febrile seizure in your early childhood. Your some family member, your neighbor, you witness this. Simple febrile seizure, generally no need to worry. Okay, but if it's a atypical febrile seizure or it's a meningitis, it should be worried. So first is definitely not a good sign. CSF white blood cell 100. This is not a good sign. Okay, then it means it's a pyomeningitis. So which of the following suggests the best outcome of the condition? Definitely meningitis is not the good. So only thing is simple or typical febrile seizure. When we use the word simple, Age of the onset between 6 months to 5 years. Duration less than 15 minutes. It's a generalized episode, single episode. If it's a febrile seizure, tell the parents your baby will have seizures whenever chance of fever till 5 year of age. No added risk of epilepsy in later half life. Relax. It's a simple febrile seizure. But if it's a complex, it's need to be worried because complex partial seizure risk of epilepsy in later life is 6 to 10%. So that is the first question of the parents. This is the seizure. Whether my child will have seizure in the later life? Yes, if it's a complex or atypical, then chance of epilepsy is 6 to 8%. Then when we called it atypical, if age is less than 6 months or more than 5 years, duration more than 15 minutes, it's the focal seizure. Only one half of the body or one limb of the body and multiple episodes. If it is there, then it is atypical. Now come to the question. Now you know seizure lasted for 30 minutes. That is not the best outcome. Seizure lasted for 30 minutes. Then it will be atypical. Not a good thing. Family report child had right-sided seizures only. Then again, C and D are the feature of atypical or complex partial seizure. It is not the good sign. So no parents want, it's a meningitis. Nobody wants fever with seizure. It should be simple febrile seizure, not the atypical. Then what is the B choice? Child is having fever. You need to look for the cause of the fever. Yes, you find otitis media on examination. Nothing else. Cause of the fever is there. Child is febrile, having seizure. It's a febrile seizure. Seizure preceded by fever where cause of the fever is extracranial. You have a cause of the fever. Treat otitis media. Everything is good. So you got this question. Which part of the story suggests the best outcome? Definitely WBC in CSF, not the best outcome. Definitely seizure lasts for 30 seconds. It's not 30 minutes, not the best outcome. Focal seizure, not the best outcome. Best outcome, fever with seizure and you have a cause of the fever, which is extracranial. Simple febrile seizure, best outcome. Yeah, typical history based clinical question. Answer this. A very common question I have discussed in my class so many times, cardio question. So those attend should be the master of this question. But see, if you are new, what is the answer? A 15-year-old female present with history of dyspnea on exertion. She has wide and fixed splitting of second heart sound. Grade 3 by 6, ejection stolic murmur. ECG show left axis deviation. Second heart sound wide and fixed split. Second heart sound wide and fixed split. Two possibility. Two possibility. Either TAPVC or ASD. If child is cyanotic, these two are the cyanotic CHD. These two are acyanotic. So first thing we look for, if child is there with wide and fixed splitting of second heart sound, we look for cyanosis. Is there? It is TAPVC. Cyanosis not there, then it has to be ASD. Second heart sound wide and fixed split in a acyanotic child. One answer in universe, that is ASD. ASD, see the question. Two ASDs are written. Two ASD. So ostium primum ASD having left axis deviation on ECG. Ostium secundum ASD having right axis deviation on ECG. Read the question. ECG show left axis deviation. Then it is classically ostium primum ASD. Watch this algorithm. This question was asked 2 times in INICET, or you can call it AIMS. one time in NEET PG. Second heart sound, wide and fixed plate, ECG show left axis deviation. What is this? This is ostium primum ASD. Ostium primum ASD. Clear? Clear? Answer this question. I want answer. Read carefully and try to answer this question. Now see, 7-month-old boy, healthy, developing normally since birth. But now report decreased eye contact. Means previously eye contact, but now decrease eye contact. So milestone are regressing. Also startle easily when there is a loud noise. What is startle reflex? If you clap, baby will do like this. Hindi mein chौंकना, baby do like this. With loud noise, it's a normal. But sometimes slight noise, baby do like this. Exaggerated startle response. Exaggerated startle response. Classical. Classical of Tay-Sachs disease. Now see, what are the feature of Tay-Sachs disease? Number one, macrocephaly. Head is enlarged. Number two, cherry red spot in eye. Number three, as our question suggests, neuro developmental delay. Number four, exaggerated startle response. These four are the classical feature. Macrocephaly, cherry spot in the eye, neurodevelopmental regression. Child is able to sit but not able to sit now. Previously child is holding the neck but now not holding the neck. Previously eye contact, no eye contact. Exaggerated startle response. Number fifth, a very good point. Tay-Sachs is the only storage disease. No hepatosplenomegaly. No hepatosplenomegaly. And number six, no treatment. Patient died in 4 to 5 years of age. No enzyme replacement yet available in Tay-Sachs. 6.6 enzyme deficiency is hexaminodase A. That is the question. Examiner wants to know these finding measurement of which enzyme is deficient. Hexaminodase A activity. Hexaminodase A activity. Very clear. Yes, you all are right. See, this is the classical clinical question. Phenylketonuria, Tay-Sachs disease, TAPVC versus ASD. These are the classical history-based question in which you need to pick cyanosis increase when you feed the child, cyanosis decrease when child is cry. History-based question, choanal atresia. Few more. Answer this. Answer this. 2-year-old boy, 2 week history of gradually increasing periorbital edema and pedal edema. Proteinuria plus, negative for blood. So what is this? This is nephrotic syndrome. Nephrotic syndrome is characterized by number one, massive protein urea. How much massive? How much massive? More than 1 gram per body surface area meter square per day. Number two, try to understand. Hypoalbuminemia. Number three, edema. Number four, hyperlipidemia. Cholesterol is more than 200. And fifth, hypercoagulability. Now remember, you are reading pediatrics, nephrotic syndrome, you should remember. Now, which of the following are true? Now, serum albumin less than 1.5, true. This is true. Serum cholesterol 130, no, it is more than 200. This is not correct. Serum complement 100, yes, it is correct. Serum complement decrease in post streptococcal glomerulonephritis. Now, if you sure that this is nephrotic syndrome, you need to give a container to the child. Baby should collect urine for 24 hours. Any spot test by which you can diagnose nephrotic syndrome? This is the spot test. Urinary protein to urinary creatinine ratio. If it is more than 2, it is spot test to diagnose nephrotic syndrome. Our question, it is given 4. So yes, A is right, C is right, D is right. Serum complement level normal. Urinary protein to creatinine ratio 4. Serum albumin less than 1.5. These 3 are true. Serum cholesterol 130. No, there is a hyperlipidemia. So yes, B is not correct. Yes, 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 Dr. Shri. Yes. Dr. Galwa, yes, you are right. So this is nephrotic syndrome. This is, you should know everything. We will discuss this when we read renal syndrome. Okay, so many syndrome, alkaptonuria, Gaucher's disease, Fabry's, clinical questions. Very interesting. I will come with some of them. Definitely. I discussed Sunday, just Sunday, day before yesterday, 2 clinical MCQ session. All are free, special classes, part 1 and part 2. Go to the Unacademy app, watch these 2 classes free. Lot of clinical question in pediatrics. You will be thrilled to know if you are watching this first time. Okay, these 2 free special classes are there. Not on YouTube, Unacademy app. Just last Sunday, 1 hour class. Watch that. Most important, keep reading. Let's crack it. If you like this session, follow me or watch further classes, or maybe share it with others. God bless you all. Thank you. Bye bye. Thank you. Bye bye. Yes, I will come with some more session like this in coming 15 days. YouTube, more clinical questions.